Hi, dear students. I'm Dr. Gaurav here again. Today, coming with a very important lecture, fractures around the hip. I know it's a very, very long topic and a very important one. So I'll just focus on two of the most important fractures around the hip, and others subsequently, other colleagues will be taking the class. So I would appreciate if you could just limit your questions to the end of the lecture if time gives. Otherwise, we'll be answering your queries in your clinical postings. I'll also leave a copy of your this PowerPoint presentation so that you can go through it later. Yeah. Right. So shall we start now? So we'll be talking about injuries occurring around the hip region. So injuries can range from various things like dislocations. If it is associated with fracture, then you call it fracture dislocations. Sometimes pelvis and acetabular fractures. But the true, fractures of the hip are called either the neck of femur fracture, inter-trochanteric fracture, or subtrochanteric fractures. These three are called hip fractures. And they can be either intracapsular or extracapsular. So as you see on the chart there, intracapsular femur, intracapsular fracture of the hip comprises of the femoral neck fractures, and extracapsular fractures of the hip comprise of intertrochanteric and subtrochanteric fractures. Yeah. So today, briefly, we'll talk about epidemiology of the hip fractures, why hip fracture is important, what are the problems associated with hip fractures. We'll talk in brief about anatomy and blood supply of the hip, and we'll discuss in detail about fracture neck of femur and intertrochanteric fractures. So please note that this sign is a symbol for fracture. So NOF stands for fracture neck of femur, IT stands for intertrochanteric. Right. So basically, hip fractures in total is more common in elderly population rather than young people, because in the old people the quality of the bone is quite osteoporotic, and they are living with many debilities like poor eyesight, blindness, or maybe impaired hearing, or sometimes Parkinson's disease and things like that. So they have often associated comorbidities, so they are prone for falls and all that injuries. So even a low energy fall, a trivial kind of a fall, a very, very low energy injury can result in a hip fractures, especially in the elderly. And it is quite rare in the young people because it is only associated with high energy trauma like motor vehicle accidents or things like that. And sometimes there is a fractures or stress fractures. So that is by giving repetitive stress to the bones. So that is actually seen in military recruits, runners, athletes, and all those people. Yeah. So why hip fractures are important? Because see, if you have a hip fractures, then it definitely affects your mobility status. You are bed bound, so your quality of life is compromised. So let's say even you're going to the toilet, you're doing your basic daily activities, that is impaired. So that significantly impairs your quality of life. So if you are bed bound for quite some days or weeks or months, then you are bound for having some complications, which I'll talk in later slides. Yeah. Right. So the thing is, please note this down: the 10% of hip fractures that die within 30 days. Irrespective of whether you treat or not. Yeah. So it is because it is associated with quite high morbidity and mortality that the hip fracture is important. They die not directly because of the complication of hip fractures, but due to indirect complications such as being bed bound and having their diabetes or cardiovascular diseases exacerbated, their metabolism impaired, and all those complications, bed sores and all those things. And 30% of them die within 1 year. So that's quite a significant amount of people with hip fractures which die within 1 year. So it's important that you treat any hip fractures as an urgent fractures in order to mobilize them and get back to their normal lives. Yeah. So these people, as I said earlier, they have often associated comorbidities such as diabetes, hypertension, COPD, or any other comorbidities. Most of them may be taking blood thinners or aspirin or any other medications. So they make the bed-bound condition to be more complicated. Yeah. So as I said earlier, death is actually due to other complications than fracture, not the fracture direct. So this is very important slide. Why are hip fractures common in the elderly? So as I said, there is resorption of the bone ongoing. So there is, there's quite not good bone stock. So the bone strength is compromised. So there is very, very easy fracture that is occurring with small velocity of injuries, such as, even slipping a step or missing a step that can cause fracture of the hip. So, and also the reduced protective responses, such as that generally old people, they are having slow reflexes to fall, and then they tend to, injure themselves. And also increased risk of fall due to impaired eyesight, Parkinsonism, dementia, and predisposing factors like, poor lighting around the bathroom, slippery floor, all those things, they contribute to fracture occurring in the elderly. And loss of local shock absorbers, that's like, in the young people, you have quite good amount of fat deposited around your hip area. And even if you fall, there's this tendency of the soft tissue to take the initial impact. So, delaying the contact time, leading to loss of kind of a shock absorption effect. So that is lost in elderly people because there is low fat reserve and they are prone for fractures. So this is yet another important slide. What are the problems you can have when you are being bedridden for a long term? Let's say the patient is not able to have an anesthesia, not able to tolerate anesthesia, and you decided to treat him conservatively and then put him on a traction for maybe about a month. So the patient is definitely going to have some other complications, such as skin complications, bed sores, which are very important. So there are starting from simple, peeling of the skin to quite deep bed sores exposing up to the bone, quite foul smelling. So that as a focus of the infection, that is one very, very important complication. A bed sore is associated with a bedridden patient. The other complications can be systemic complications, such as, when you are bound to bed, your intestines are not moving, so you are having constipation, you are having less fluid. So the chances that you are having paralytic ileus, and when lying on the bed, there is a tendency to have a chest infection, hypostatic pneumonia. In case of catheterized patients, you can have urinary tract infection. So when you are having a catheter for a long, long time, your bladder capacity tends to decrease. So that's called bladder atrophy. You tend to develop stone around the focus of the catheter. So you can develop urinary calculus. And there is always significantly associated, sodium potassium disbalance in these kind of bed-bound people. You can have deep vein thrombosis, which we'll talk in later lectures. Quite important thing, because there's a hypostasis going on. So leads to deep vein thrombosis and further complications. Thrombophlebitis, if you are using cannula and all this stuff, and if you are not using the muscles quite significantly and the joints, you are bound to have disuse atrophy of the muscles and joint stiffness. And in addition, you have metabolic complications, like blood sugars and everything that is not well controlled when you are bedbound. Yeah. So briefly talking about anatomy of the hip joint. So hip joint is quite a strong joint of the body, which is a multi-axial axis, ball and socket type of a synovial joint. So it's a very stable joint. The stability is given by the anatomical structure of the cup acetabulum, where the ball and socket joint is quite inherently stable joint. It is supported by very, very strong ligaments around the hip joint. So it's quite significant injury that needs to disrupt these tissues. So it's a synovial joint after the knee joint, I believe. Knee joint could be the largest joint of the synovial joint of the body. So the importance of this hip joint lies in that, the weight of your upper trunk, the pelvis, abdomen, and the part above, that is transmitted to the ground through your hip joint, and that acts as a fulcrum. So, tremendous amount of forces they are acting at the hip joint. So let's just briefly know there are these trabecular systems which are evident in the X-ray, in the good quality X-ray. If you see, these lines, these kind of wavy lines going from in this direction. So if it is represented here. So how to remember is, this concave side of the bone is always compressile side. Yeah. So that's the inner side is the compressile side, and the outer side or the convex side is always the tensile side. Yeah. So can remember, there are primary tensile, primary compressile, primary tensile, so tensile will originate from this side, compressile will originate from this side. So this is primary compressile, secondary compressile trabeculation system. This will be the primary tensile thing is here, the secondary compressile trabeculaire, and you can have a clear area around here. So roughly you cannot make a triangle, but here it is represented, roughly there is this wide triangle around it. So just make a note of this, because according to these trabeculations you can either classify fractures and the amount of osteoporosis that will come in subsequent lectures. Not need to remember now, but then just making you aware that there are such things called as primary and secondary compressile and tensile trabecular system. So one important line in consideration with the hip joint is the sentence line. Some people call it sentence arc, because it's not a straight line, it's a curved line. When you draw this line through the inner border of the femur, traveling up through the lower border of the neck, going through the inner lower border of the superior pubic ramus. So that should form a smooth arc kind of a thing. So that's known as a sentence arc or a sentence line. So if there is any break in this line, let's say around here or here or here, so that suggests neck of femur fracture. So sometimes neck of femur fractures can be quite tricky and it's not evident on X-ray, and in that cases you might need a CT or MRI. So in that cases your sentence arc that can come in handy. Yeah, just to let you know. So you should know blood supply to the hip joint, which is very important thing to know. So it says precarious blood supply. So that's precarious means quite important and quite precious kind of a blood supply. So that is formed by medial and lateral circumflex femoral arteries. So they form, at the base of the neck, they form a extracapsular. So this thing lies outside the capsule, extracapsular arterial ring, in the anterior as well as posterior. So that's a ring-like structure. From there are ascending retinacular vessels, cervical arteries. Cervical means with the neck is also called the cervical region. So ascending cervical arteries, when are going as they are going there, they again form another ring there at the base of the head. So that this time this is subsynovial, intracapsular. So this is subsynovial and intracapsular arterial ring again is formed just at the base of the head. Yeah. And this is the blood supply of the adult skeleton. So in children, there is another dominant blood supply coming through the ligamentum arteriosum, ligamentum teres femoris, through the head of the femur. So that is more significant in children blood supply. Yeah. So neck of femur fractures basically are the fractures occurring from the inter-trochanteric line up to the head. So these are further intracapsular fractures. They are further divided into either subcapital fracture if it is occurring through the neck, that's transcervical fracture, and basicervical fracture. And sometimes if it occurs through the cervical neck and the trochanteric junction, that is called as cervicotrochanteric. So basically 4 kind of neck of femur fractures. So we'll briefly go and classify. So clinical features for any fractures and in orthopedics, as you say in medicine, auscultation, palpation, percussion, and those things. In orthopedics, it's look, feel, move, and measure. Yeah. So clinically, it's female are more prominent. So it's typically a female patient, quite elderly female, frail kind of osteoporotic lady. So they present with a history of fall or trivial injury. They might sometimes present with just limping, pain around the hip joint, and they'll say they are unable to stand or walk on the affected leg, unable to stand up, and they point to any pain around the hip joint. And sometimes, because it's intracapsular fracture, you don't see quite swelling around the hip joint or bruising around the hip joint because it is intracapsular. So basically, the signs, the visible signs will be that the patient will have a shortened leg, shortened length of the limb. So when you compare both the medial malleolus around the ankle, one of the medial malleolus is at the higher level, so suggesting shortening of the leg. Yeah. So the foot will be externally rotated. So as you compare, if you see from the foot end of the patient, let's say if this foot is normal, you will see a kind of a foot externally rotated, not towards the parallel to the bed, but somewhat externally rotated, saying that the neck is fractures, but still the capsules and those things, they are holding the fracture in position. And there is tenderness around the hip point, that is midpoint of the inguinal ligament. If you ask the patient to raise the leg from the bed, they are unable to do so. Why? Because the fulcrum is broken now. So if you have a fracture of the neck of the femur, that's the fulcrum. So if the fulcrum is broken, no matter how much effort you give, you are not able to lift the leg. And if you measure, there is this shortening at the supra-trochanteric level. Yeah. So broadly classifying, you need to know these three names. Garden, that's the important classification. So that gives a classification based on the fracture displacement. So Garden 1 will be undisplaced kind of a fracture. There's just an incomplete fracture line, and the fracture head might be just impacted. Grade 2 will be a complete fracture line, but fracture is not very displaced. Grade 3 is a displaced fracture, and grade flow is significantly displaced. Yeah. So Garden will have classification based on displacement. So we'll come to another important classification, Powell classification. So that's basically based on the angle subtended by the fracture line to the horizon. Yeah. So if you see, this fracture line is quite horizontal, quite less, and if you compare it to horizontal, that's come to around 30 degrees, less than 30 degrees. So that's type 1, 30 to 50 degrees, and 30 more than 50 degrees type 3. Why these angles? Because the more the angle, the more the shearing force is between. Shearing is this kind of force. So inherently, if it is this kind, so it's quite stable. But if it is like that, you tend to have more instability at the fracture site. So more the angle, more is unstable. So that's the Powell classification. And Delbet is another classification usually used in children. That's based on the anatomical location of the fracture. So that divides you into subcapital fracture, a transcervical fracture, a basicervical fracture, or a cervicotrochanteric kind of a fracture. Yeah? So very important to know, these neck of femur fractures, they go into non-union. There are specific reasons why neck femur never heals itself. It never heals itself, unlike other bones in the other part of the body. Because, the uniqueness is that periosteum in the femoral neck, it is devoid of cambium layer, so which is the mesenchymal stem shell rich layer. So if it is absent, then you have naturally, less effort of healing and, self-differentiating cells. There's no healing effort. So also because it's intracapsular fracture, the capsule is having a synovial fluid. Yeah? So the fracture hematoma which is collected there is diluted by the synovial fluid. So as it is diluted, so there is less inflammatory response for healing. Yeah. So also the synovial fluid, it has some kind of anti-angiogenic factor. So when there is no angiogenesis, there is less inflammation and less chances of healing. So as I said, there is high shear stress. Shearing force is like when one force is trying to translate over another. So because the bone is directed like that, so in the weight transmission, there is this high amount of shear stress occurring around the fracture site. So when you have shear stress, there is persistent mobility at the fracture end, so no healing. And also that because the synovial fluid is there, you get additional hematoma, and you get a tense fluid around there. So what it does is like tamponade. Tamponade is giving pressure. So when the intracapsular pressure significantly rises, it compresses the all those retinacular vessels and your subsynovial vessels. So there is further reduced blood supply to the head and the neck region. So that further adds to delayed healing. Yeah, I should run fast now. So treatment choice depends on age, physiological age. So let's say if the patient is around 30 years having a neck of femur fracture, you always want to preserve the head, his native head. But if it is old person, 70, 80, you know that the healing is not going to be good. There is no point in preserving the head. You get rid of the head and do replace the head with metallic prosthesis. So another important factor is pre-injury mobility status. If the patient is already bed-bound before injury, so if you are doing surgery by the patient, then you are not going to make any difference. So if the patient is actively mobile before injury, kind of a community ambulator, if he's using walking sticks to walk around, then it is worthwhile to take the risk of the surgery and make the patient up and about. And you take into consideration, because these people mostly have comorbidities, you see whether they have diabetes, hypertension, CVA, ischemic heart diseases, COPD, Parkinson's, Alzheimer's, or mental retardation, all those significant factors that they help you decide what kind of treatment which you give, yeah, either a total hip or a half hip replacement. So these are the factors which make you decide. And mostly the activity level of the patient and the expectation of the patient. Let's say if the patient is a teacher whose job involves standing for about 6-8 hours a day and then quite active life, and you want to give him back that life by treatment. So you don't want him to do a fixative surgery and ask him to rest in bed for 6 weeks. You just want to replace his head, and straight away within 2 weeks you want to send him back to work. You want to give that same kind of activity level to the patient back after the surgery. So these are important factors which determine the treatment outcome, yeah, or the treatment choice. So whatever the treatment implant you are using or things, the aim is basically to mobilize the patient up and about out of the bed as soon as possible in order to avoid the complications of bed-ridden complications. Yeah? So goals would be, you restore the hip function, you give the patient independence, so that means return to normal activities of daily living. You give the patient pain-free hip, so that's adds to the patient comfort. Try to early mobilize the patient, so that reduces the length of the immobility. So this remains the goal of the treatment. So non-operative management, let's say in any patient, if it's a terminally ill cancer patient who is expected to survive about 6 months or 1 year, why would you want to do such a major surgery with so many risks just for additional 1 year? So in that kind of a patient, or if the patient is very, very sick enough to not tolerate anesthesia to undergo surgery, then you offer this non-operative management, which is basically by asking the patient to just move in either crutches, or the crutches is this one, or in the Zimmer frame. You call it Zimmer frame, quite stable for old people to walk around. And so this is called supervised neglect. So you know that it is not going to heal, but then you still are mobilizing the patient. So this is quite rarely done, only in very few patients. So the operative management, very important slide. So let's say if it is a young patient, you want to preserve the head. Why? Because the native head has got a good blood supply, and it should be lasting for a long time. But if it is a prosthetic hip, it has some drawbacks, because its lifespan is maximum about 20-25 years. So you don't want to repeatedly do surgery in a young patient. So if it is a young patient, you try to preserve his head as far as possible. So the options would be close reduction and internal fixation. So you take the patient under operating theater, you reduce the head, under the C-arm image intensifier and fix it with cannulated cancellous screws. Yeah. So these 3 screws, they hold the fracture in position, and you ask the patient to, non-weight bearing for about 6 weeks, 8 weeks till the fracture heals, and then, ask the patient to go back to normal activities. So the other options would be, you use a short DHS with a derotation screw, so that, it prevents the head from rotating and, adds to stability, as well as, preserving the blood supply of the hip, so that allow it to heal naturally. But if it is an old patient where you don't want to, additionally have this burden of trying to preserve the head, it will undergo avascular necrosis, and you have to have a repeated procedure. So in that case, you already do a one-shot procedure. So that's either, girdle stone excision arthroplasty is just taking out the head and, just making the hip done, just for enumeration I have given here. But the 2 important other treatment choices would be hemi replacement arthroplasty, HRA, which is a half hip replacement, saying that, this is stem there, and the head, you are giving the head, but you are not touching the acetabulum. The acetabulum is intact, the native acetabulum of the patient, but only you replace the head, the broken head and the neck. Whereas if you do a total hip replacement, or you are replacing the acetabulum surface as well. So this is actually done for quite young, I mean, in comparison to, let's say if the patient is around 70 and you expect the patient to live around, another 20, 25 years, you would offer a total hip arthroplasty. But if the patient is, expected to live around 5 to 10 years, then this hemi replacement arthroplasty is a good one. So replacement surgery basically can be hemi replacement arthroplasty, which is replacing the femoral head and neck only. So this can be either unipolar prosthesis or bipolar prosthesis. Unipolar can be Austin-Moore prosthesis, the one here with the holes, the fenestrations here. This one is the Austin-Moore prosthesis, and the other one is Thompson prosthesis. So these are examples of unipolar prosthesis of hemi replacement arthroplasty. So this is half hip replacement. Yeah. So there is another thing as known as bipolar prosthesis. I don't have the photo here, but I can show you whenever you are in clinical posting, just to let you know. So these are basically a shorter operative procedure, but the only disadvantage is, the implant survival is quite less, maybe around 5 to 10 years. So if the patient tends to survive for more than 10 years, 15 years, then that needs to be replaced. So you give it to patients who have life expectation of around maybe active life of around 10 years. So, but the advantage is this is shorter procedure, less expensive, and technically very simple, and can be done anywhere with pretty much ease. Yeah. So total hip replacement, on the other hand, is a quite technically more complex and challenging surgery, more expensive surgery, and has a longer procedure. But the advantage is that it aims to restore the normal biomechanics of the hip, saying that your functional demands, if it is high, if your activity involves mountain climbing, swimming, or horse riding, or those kind of stuff, then you want to give the patient a total hip replacement. I need to run fast. So total hip is basically cemented, uncemented, or hybrid. Yeah, just to let you know. Complications can occur from simple complications as with any surgery, like infection of the wound, bleeding complications, implant failure, such as breakage of the implant, loosening, dislocation of the prosthesis. Questions at the end, please. Leg discrepancy. That's either you are making the leg long or short. So the patients become unhappy with that. So you tend to have a deep vein thrombosis in the post-operative period that can occur, that can cause pulmonary embolism. That's another fearsome complication. Sometimes you can have a sciatic nerve palsy. Sometimes when you are using the bone cement, there can be a hypersensitivity and kind of a embolism kind of phenomenon known as cement syndrome. Yeah, and sometimes you need additional surgeries if the surgeries go wrong in the first place. Yeah. Now let's quickly run to inter-trochanteric fractures. So these are, in contrast to neck of femur, these are extracapsular kind of hip fractures. So the fracture line basically extends from the greater trochanter towards lesser trochanter. Yeah. So GT is attachment of the hip abductors there, and lesser trochanter is attachment of the hip flexors. So there is this fractures lines, and the fracture bone ends, they are being pulled away in either direction. So that's quite an unstable kind of a fracture. So again, this fracture is quite common in the elderly. The female is common. The patient will give you a history of fall, occasionally more predisposing factors such as I discussed before, they will be present. Here the clinical feature is, you can have swelling in the proximal part of the thigh, and more evidently it will have, bruising around the hip region, or you can see quite visible ecchymosis because it's an extracapsular fracture and the blood is extravasating in the subcutaneous tissue, and you can make it out from there. So one difference will be like, the patient will be similarly unable to weight bear, quite frail patient. But the one significant difference will be the foot position will be more externally rotated. It's almost parallel to the bed of the surface, surface of the bed. So as compared to the neck of the femur fracture. So that's one important differentiating point. So there are many classification systems for inter-trochanteric fracture, Boyd and Griffin, AO, OTA, orthopedic trauma association fracture, Russell and Taylor classification, Evans classification. So you don't need to go in detail with it, just know the names, but you need to know in detail about this Boyd and Griffin classification. Yeah. So basically it talks about, stable two-part fracture. Yeah. And type 2 will be unstable comminuted kind of a fracture, but the lesser trochanter is intact. Type 3 will be unstable reverse oblique kind of a fracture. So instead of, from GT to LT, you'll have a fracture line extending further down. So type 4 is again unstable fracture, inter-trochanteric, subtrochanteric with two planes of fracture. So you can go through the slides later on. Yeah. So there's this picture of the reverse oblique fracture pattern. So conventionally, inter-trochanteric fracture, the fracture line would be running from greater trochanter to lesser trochanter. The fracture line would have been like this. But here, if it is reverse oblique, the fracture line is extending further down there. So that makes it inherently very unstable fracture. More or less all of the inter-trochanteric fractures, they need to be fixed. So in management, in emergency, as the patient comes, you give the leg traction, skin traction in order to reduce the pain, so that you are aligning the bones together. You give the patient analgesics, you give some IV fluids, you take the patient to ward, you send pre-operative investigations, and these patients invariably have some comorbidities such as diabetes, hypertension, COPD, all those things. So you optimize for surgery and prepare for surgery. You target to give them surgery within 24 hours or 48 hours at the most. So there's an international protocol that you should operate all hip fractures within 48 hours. Otherwise, they go into decompensated kind of they tend to go downhill and deteriorate. So if you are offering non-operative treatment, there's this thing called as a boot and bar plaster. So this is basically plaster worn around the lower end of the leg with this kind of a bar there, so that your foot is kept in neutral rotation and allowing the fracture to heal, because there's good chance that it can heal by non-operative method because it's an extracapsular fracture. So all those risk factors of non-union don't come into inter-trochanteric fractures. So another immobilization method is Thomas splint. So what are the goals of the surgical treatment in IT fracture? So you want to give the patient a stable fixation, and you want to restore as anatomically as possible. So in order to give a normal femoral neck shaft angle, which is about 125 degree, you want to mobilize the patient early out of the bed and avoid any complications of recumbency. Yeah. So operative treatment, the choices are either dynamic hip screw or dynamic condylar screw or proximal femoral nail. Yeah. So this is a DHS, a dynamic hip screw. So this is angled around 135 degrees, comprising of outer barrel plate. They have this Richard lag screw, the one which is going inside, and it has a compression screw to give a vertical screws there holding the barrel plate to the bone. So the other will be a dynamic condylar screw, kind of you tend to give it in a more unstable kind of a fracture or subtrochanteric fracture. So that's basically having a 95 degrees barrel. Rest of the things are same. Whereas proximal femoral nail is a quite stout and thick intramedullary device, goes inside the femoral canal there, and this one goes inside the femoral neck. So thereby, you want to give a good stability and start the patient mobilizing from day 2. Yeah. So if the patient is unfit, for surgery, and the shortest surgery you want to give is external fixation. You design a kind of a pins which are inserted there, around the bone, aligning the fracture and holding it like that. But the disadvantage is always that it's quite cumbersome, and the pins are sticking out of your body. You tend to have infection around this pin track. There's always this chance of infection going inside the bone and having osteomyelitis. So not really practice nowadays, just for your. So post-operatively, you want to give the patient analgesia and antibiotic, physiotherapy. You want to dress the wound. You want to mobilize the patient. You want to give DVT prophylaxis by giving low molecular weight heparin, and you want to prevent infection because you want to give antibiotic prophylaxis for like your heart valve patients whenever you are doing any additional procedure. So there's no need to remove this hip implant, so they go on for life. So this last slide is basically for you to know what are these important things from exam point of view. Yeah. So you should know classification of neck of femur fracture and IT fracture. You should know which is extra and intra. What is the blood supply pattern? What is Shenton's line? Why it is common in elderly, both the NOF and all these hip fractures? Why high morbidity and mortality are associated in neck of femur hip fractures? What are the surgical determinants and important determinants in deciding surgery? What are the available options for surgeries? What are the complications of surgeries? And what is your ultimate goal and aim in treating the patient? Yeah. So this pretty much completes your lecture for fractures around the hip. I know it's a very, I had to run through. I'm sorry, but I'm quite happy to leave the PowerPoint presentation with Mira, so she can give it to you, and we can always discuss it further. If you have any queries, I'm happy to answer. Yeah. Any questions? Yes, I'm expecting more. Time can be extended. I'm sorry. I have got my OPD to see. Yeah. Shenton's line is also broken in posterior hip dislocation. Does it mean NOF fracture is also present? Yes. In dislocation, it can have, neck of femur fractures associated. Yeah. It's not necessarily that, NOF fracture is only for, Shenton's line is only for NOF fracture, because any break in that line means either there's the pathology in the hip, inter-trochanteric fracture, neck of femur fracture, fracture dislocation of the acetabulum. So yeah, quite a good question. What is this Reeth Bathar? Any questions?